Hello, everyone, and welcome to today's edition of Podcast. Hope you all are keeping safe amid these very challenging times for all of us. Today is April 30, 2020. I am Rifat Mannan, and I am remotely joined by my good friend Emilio Madrigal, who is in Boston. Today, we are excited to welcome Dr. Ivan Bloch, who is an associate professor of transfusion medicine in Johns Hopkins University. He's going to discuss on a very relevant topic in today's time, that is convalescent plasma as an emerging therapeutic option for patients with COVID-19. And the title of the topic is Convalescent Plasma for Prevention and Treatment of COVID-19, an old hope for a new disease. As
Hello.
always, please feel free to post your questions and comments on Facebook and YouTube chat windows, and Dr. Bloch will be happy to answer them at the end of the session. Thank you, Dr. Bloch, for joining us today,
Sure.
and over to you.
So first, thanks very much to Rifat, Emilio, Kim, and others for the kind invitation to speak today. As Rifat mentioned, the title of the talk is Convalescent Plasma for Prevention and Treatment of COVID-19, an Old Hope for a New Disease. So just a few disclosures. I'm a member of the FDA Blood Product Advisory Committee, so any views or opinions that expressed in the presentation are entirely my own. I have given some educational talks for Grifols and Terumo, and I'm a co-investigator on two clinical trials of pathogen reduction using a commercial technology, but that's entirely unrelated to the contents of today's talk. Another disclaimer is that most of what I say could change and probably will change in days to weeks, probably for the better. So the objectives are firstly to review the evidence that supports CCP stands for COVID-19 convalescent plasma as prophylaxis and treatment for COVID-19. I'm going to run through the different pathways for hospital access to CCP, and I'll give you the status of each of those pathways and some of the challenges that have been encountered along the way. Summarize the research surrounding CCP. How hospitals can contribute, the operational considerations that you may be asked about, and then finally, kind of what's quite interesting is the ethics of use. So just some background, in case you've been hiding under a rock for the past 3 or 4 months. There was an epidemic of acute respiratory syndrome in humans, first described in Wuhan, China, dating back to about 12th December 2019. So the initial cases were linked to an animal and seafood wet market in Wuhan. This prompted, correctly so, concerns over zoonotic origins. So that unfortunate animal in the top right-hand corner is one of the bat species, which is probably in some ways where probably responsible in some part for the origins of SARS-CoV-2. So the virus is a large lipid-enveloped, positive-sense, single-strand RNA virus, about 80% sequence identity to the original SARS coronavirus of the 2003 outbreak, about 88 to 96% identical to a bat coronavirus if it looks at it at a whole genome level. In terms of taxonomy, it's a beta coronavirus. There are 4 structural proteins, which becomes relevant when one looks at the testing. Specifically, the spike protein has been a useful target for some of the tests. And it employs the virus employs the same receptor as the original SARS coronavirus, which is human angiotensin converting enzyme 2. And the spike protein binds to host receptors via receptor binding domains, which is another target for testing. So droplet and person-to-person transmission in community and healthcare settings have been responsible for the global spread. Just an interesting piece about the basic reproductive number. So that's the infection in susceptible population from a single infection. So the classic measles is really one of the most infectious viruses. When we look at SARS and COVID-19 or SARS-CoV-2, both airborne droplet spread and have modest to high high reproductive numbers. So fast forwarding 4 months, we've just hit a pretty horrible milestone of about over 3 million cases worldwide, spanning 185 countries or territories. There's been over 1 million cases in the US alone, over 60,000 deaths. Testing has ramped up considerably. We're now about 6 million tests to date. And there's been about almost 230,000 deaths in the US. The important piece about this is that we almost certainly underestimate the true burden of disease if one actually looks at some of the resources which are tracking the numbers. Most of the countries are low middle income countries which don't have the same capacity for surveillance as the US and other high income countries. So in terms of the clinical burden, there's a whole wealth of literature on this. I'm sure you're probably aware of some of it, but there was a nice paper, I think it was last week in JAMA, which kind of illustrates some of this. So the study reported it was a case series of patients with COVID-19, over 5,500 patients admitted to 12 New York hospitals in basically a 1-month period, so March to April. What they found was that most were of advanced age, median of 63 years. There was a male predominance, about almost 60% were male. Most common comorbidities were hypertension, obesity, and diabetes. And at triage, almost a third were receiving supplemental oxygen. They then looked at a subset, about 2,600 patients, either at death or discharge. About 14% were treated in the ICU, 12% had invasive mechanical ventilation, 3% kidney replacement therapy. And if one looks at mortality, about 20% of those in that population died, and 88% of those who required mechanical ventilation died. So just illustrating the high mortality. So kind of moving towards convalescent plasma, I'm going to give you what I call a toddler's guide to immunology. So why antibodies might be important. So, the general idea is an individual is infected with a pathogen, doesn't have to be a virus, can be a bacterium. There's an immune response. Part of that is the humoral immune response, which relates to antibody formation. In the case of SARS-CoV-2, those antibodies become detectable from days 8 to 21. There's actually probably a wider spectrum. I've seen as early as 3 days post symptoms. The antibodies have a variety of effects. So there's neutralizing antibodies. So there's direct binding of the virus. There's also antibody mediated the antibody mediated immune pathways such as complement activation, antibody-dependent cellular cytotoxicity, opsonization, and or phagocytosis. There's also kind of a less well-understood contribution of non-neutralizing antibodies, which bind to the pathogen, at least in vitro, and may contribute to prophylaxis and or enhanced recovery. So the premise behind convalescent plasma is relatively simple. It's really passive transfer, either through transfusion or infusion, of antibodies from a convalescent individual into a recipient, either someone who's at risk of infection or is already infected with a virus, as in they have COVID-19. Importantly, passive antibody administration is the only short-term strategy to confer immediate immunity to susceptible individuals. But starting just out the gates, it's important to note this is not ideal. It is really, I view this as a temporizing measure, pending availability of more refined or durable strategies, such as either for treatment, so there's things like hyperimmune globulin, monoclonal antibodies, or direct acting antivirals, and or prevention. The ideal is really the vaccine development, but this is available now versus we're at various stages of development with those other modalities, which could be months to years from implementation. So there's already historical precedent for use of convalescent plasma, remote historical examples as well as modern recent examples of, I say successful. I'll let you be the judge of that. Put that in quotation marks. So it's been used for post-exposure prophylaxis, for diverse infectious diseases, hepatitis, mumps, polio, measles, rabies, and importantly, it's been used for over 100 years. For treatment, some of the agents that have been treated include flu, Argentine hemorrhagic fever, Ebola, the original SARS coronavirus, Middle East respiratory syndrome, so MERS, as well as it's been used already relatively effectively in COVID-19. Very importantly, it seems to be safe and effective. So some of the outcomes that have been looked at include reduction in viral loads, improvements in cytokine responses, and clinical outcomes, including survival and shortening of hospitalization. So another important point is that administration early in disease course is thought to be better. So that's what we take from from all the prior literature. So one example of that is the Spanish flu, the H1N1 pandemic of 1918 to 1919. Nice meta-analysis which looked at the studies related to that. Going to take some of those studies with a pinch of salt, using different approaches from 100 years ago. But if they looked at the crude case fatality rate, if convalescent plasma was administered less than 4 days from symptom onset, the fatality rate was 19%. If one left it, went up to about 60% beyond 3 days. So it's been used many times. So the central question is, does it actually work? So I'm going to give you a couple of examples, and then, as I say, I think I'll leave it to you to decide. So Argentine hemorrhagic fever seems a little bit random, but it's actually probably the best example of use. There was a double-blinded placebo-controlled trial in the 70s. So as patients in Argentina were hospitalized and administered convalescent plasma or placebo within 8 days from onset of symptoms, that each patient or subject received 500 mils of either immune or non or just normal plasma. And the donors had been characterized as in they were known to have a 4-fold or greater rise in antibody titers as determined by complement fixation. So the case fatality rate in those who received the convalescent plasma was 1%. In those who received the non-immune plasma was 16%. Some recent examples. If there was a trial of moderate to severe flu from 2011 to 2015, it's a randomized open label trial. They're recruiting hospitalized children and adults with severe flu A or B. Severity was determined by the presence of hypoxia or tachypnea. And the intervention was 2 units or pediatric equivalents of anti-flu plasma plus standard care versus standard care alone. And again, those units have been characterized and each had a titer of 80. So the subjects were followed up for 28 days. While the plasma was found to be safe and well tolerated, there was a non-significant reduction in time to normalization of patients' respiratory status, which was really the primary endpoint. Another example was the, I don't know if you call it the epidemic in West Africa. So a trial or it was a study in 2015, a non-randomized comparative study of patients of various ages with confirmed Ebola. So each subject received 2 consecutive transfusions within 2 days of diagnosis with Ebola. Unfortunately, the level of neutralizing antibodies was unknown at the time of administration. And the control group was over 400 patients who had been treated at the same center during the previous 5 months. The primary outcome was risk of death 3 to 16 days following diagnosis. Ultimately, risk of death was about 30% in the convalescent plasma group, 38% in the control group. And the conclusion was, while there were no serious adverse events, it was not associated with a significant improvement in survival. So what about coronaviruses? Because I guess that's a little bit more relevant to what we're talking about. So if we look at SARS-1, there was actually a number of studies which reported use. The best was an 80-patient study in Hong Kong. It was where there seems to be a good clinical outcome in about 40% of the patients, as defined by hospital discharge by day 22. So there was improved outcome. Improved outcomes were associated with early administration, again consistent with what I was saying previously, and there were no adverse events. In terms of Middle East respiratory syndrome, much less data. There was essentially only one. There was a small, I don't know if you call it case series at the top, where there were 4 transfusions of convalescent plasma to 3 patients. The volumes were not stated, but those units were characterized, and the investigators concluded uncertain benefit. There was another feasibility study, which, while not related to transfusion of convalescent plasma, this was really to look at antibody development in those who had either been exposed or were known to be confirmed with MERS. And the important takeaway from this was that there was actually a low proportion of individuals, either following exposure or following actual infection, who developed neutralizing antibodies, which could impact, had this gone on to larger epidemics, that would have affected the feasibility of use. And then last one at the bottom is just a case report in South Korea, where they gave convalescent plasma, and then they reported on a case of possible transfusion-related acute lung injury, or TRALI. So what about early reports of convalescent plasma specific to COVID-19? So we're already far ahead, and now we fortunately have some experience with COVID-19. So the first study was an uncontrolled case series of 10 severely ill patients in Wuhan. The median onset of symptoms to administration of the convalescent plasma was about 16 days. Each of the subjects received 200 mils of plasma with a known titer against SARS-CoV-2 exceeding 640. So there was no significant adverse effect, which is important in terms of a safety signal. And there was an improvement in clinical status of all patients, as evidenced by improvements in symptoms within 3 days of transfusion. There was radiological improvements in pulmonary lesions, and there seems to be a temporal reduction in viral loads in some of the subjects. In Shenzhen, also in China, during their epidemic, there was another report in JAMA of an uncontrolled case series of 5 critically ill patients, kind of variable as to when convalescent plasma was administered, up to 22 days post-admission. There were 2 consecutive transfusions of 200 to 250 mils each, so a total of 400 mils. Again, these were well-characterized units with neutralizing titers exceeding 1,000. Exceeding 40, and then an ELISA antibody titer of over 1,000. And they reported improvements in clinical status for all 5 patients. There was weaning off mechanical ventilation, there was reduction in viral load, improvements in oxygenation, and clinical stabilization. So it all sounds very positive. What's the catch behind this? Well, in both studies, all had competing therapies, including steroids, antimicrobials, and antivirals. So it's difficult to tease apart what was the contribution of convalescent plasma in all of this. So summarizing the evidence, first, it's generally well tolerated. So adverse effects are few. But the efficacy data are really mixed. For one, convalescent plasma is typically deployed in times of emergency. The studies that have been reported suffer from serious methodologic limitations. Specifically, there's a lack of blinded, randomized, or placebo-controlled trials. That's why I put up the Argentine hemorrhagic fever case is really the exception. And very different infections have been treated. But what is consistent among the different studies is that early administration seems to be associated with better outcomes. So, titled is The Beginnings of an Initiative to Study Convalescent Plasma in COVID-19. So just a little bit of, regulatory, insight. So blood is a biologic. So at least in the US, blood is overseen or regulated by the Federal Drug, or the FDA. And so there's something called an IND. So any modification of a blood product or any test which is developed specifically for testing blood for transfusion has to go through what's called an investigational new drug pathway, or IND. That's what I've just said over there. So fortunate, I'm happy to say that we submitted IND applications to use convalescent plasma both for prophylaxis, which was cleared, which is a terminology. So an IND is not approved, it's cleared. And then secondly, for early treatment, we obtained clearance for that as well. So there's different access pathways for convalescent plasma. So the first is EIND, which stands for emergency IND. So this is emergency use for severe and life-threatening COVID-19. And I'll give you detail on what this means and how to kind of access it practically in the following slides. The second is an expanded access program, which is a government-led treatment protocol for treatment of moderate to severe COVID-19. And the third is a traditional IND pathway, which is ready to support research. What I'll talk a little bit about is the clinical trials. And each of these pathways is at different stages of development. Soon we should see that all are pretty active. So, the access pathways were defined quite early. I keep on saying this, what's the catch? This is an enduring theme. So the challenges are foremost is really this massive unmet need. And this is really going to be a mixed message, because I'm always torn about calling something an unmet need when we haven't demonstrated efficacy. So there's a current lack of availability of products for the individual pathways. That is certainly known. So practically for someone on the wards, how does this all apply? So emergency IND, what happens is if an individual provider has a patient who qualifies and the eligibility criteria for life-threatening or severe COVID are outlined on the FDA website, then one can apply for this emergency IND. It can be expedited fairly quickly. So literally within hours, one can obtain approval, and then one works with one's blood provider through the transfusion service to obtain a product for emergency use. So under this model, the hospitals are recruiting donors, and it's kind of this reciprocity where the donors are then referred to the blood center then collects the units, and then they go back to the referring hospitals. That introduces some challenges surrounding equitable distribution, because not all hospitals have the same level of capabilities with respect to recruiting donors. A lot of this is changing favorably as blood centers are able to build up inventories. The next is the expanded access program. Over here, an institution registers centrally through this government-led program. So Mayo Clinic is the data coordinating center. American Red Cross is the major provider, although a lot of the major blood collection centers are also participating. So through this expanded access program, a participating institution gains access to a central inventory. So they identify a patient in need, and then they apply to their regional provider for those products. And these the products are I think it's a negotiated cost with through the government, and as a result, hospitals are not billed for those products. as part of the commitment to, as participation in that program, is reporting of minimal, albeit high yield data. So adverse events, outcomes at 7 days, 30 days, or discharge, whichever comes sooner. So there are some significant challenges, which are fortunately getting better as we kind of navigate some of this labyrinth. So the first step is scale up and access to the product. So recruitment and vetting of donors is probably a major hurdle. And the blood centers have been at various stages in their response in terms of scaling up their plasma collections. So there's this unmet need with very little standing inventory. So any requests, those products are straight out the door. But there is a somewhat of a chicken egg problem, because if there's no inventory, it risks curtailing requests for those products, because we kind of adapt. There's no point in going through an IND mechanism to request something which is not available. There are changing criteria for eligibility. So originally, if one was to recruit a donor, there's lots of people want to donate. The first thing is they need to have a history, ideally of confirmed COVID-19, as in they had a molecular test at time of symptoms. And at the beginning, there was the need for a follow-up negative test. There still is a need for a follow-up negative test if between days 14 and 28. So one can donate as soon as 14 days post resolution of symptoms. The catch being that one requires negative testing. And negative testing is not easy to access, so that's been a big hurdle. So there have been some relaxing of those criteria. So now the FDA allows for evidence of COVID-19 by virtue of antibody detection. And the catch with that is that one doesn't necessarily want to select patients who've had symptoms but haven't necessarily had haven't had a confirmed diagnosis, because then one risks being inundated with not so much test seeking, but just people who are just overly sensitive to what their symptoms might be. Some of those cases may be COVID-19, some of those may be just anything else. There's also a series of administrative hurdles which have been fairly formidable. So, just as an aside, so the typical research life cycle from proposal to analysis is really months to years. So the systems in place at institutions are very well adapted to a highly regulated research environment. So in order to contend with the oversight and the reporting requirements. So this is really, it's complex, multidisciplinary. No decision is really made alone. There's multiple layers of committees and subcommittees to kind of vet research and make sure that it's performed ethically and that it poses low risk to institutions. It's deliberate, thoughtful research, which in a normal world is ideal, but it's totally at odds with pandemic responsiveness. And kind of my take home from this is that as we hopefully move beyond COVID-19, there will be some need for development of kind of I describe this as like the martial law of research or intervention, where one can actually cut through some of these systems more efficiently. Another major challenge, which you're probably aware of, is antibody testing. So for one, it's not widely available. For another, it's not standardized. So we look at testing. We have neutralization assays, which are really the gold standard, such as the plaque reduction neutralization test. And on the other side, you have these kind of EIAs or ELISAs. So the neutralization assays are the ideal, but they're impractical. They require BSL-3 laboratories, long turnaround times of 5-6 days plus. So just not really available. If we look at just the EIAs or the ELISAs, what we don't know right now is, you can say, well, we have antibodies, but what isotypes and or subclasses of antibodies are optimally effective? So is it IgM? Is it IgG, and embedded within IgG, is it, which of those subclasses is it? Does IgA have a role? Should we look at IgM as well? Should we look at total antibodies? What is the optimal titer? Do we really know the kinetics of infection? This is beginning to be revealed. So I mentioned at the beginning, there's seroconversion about 8 to 21 days post-infection. There's variability in the assays and where they're being undertaken. Some are being performed in a clinical labs, others in a research setting. We've got commercial assays, we've got in-house assays. Some are approved, most are unapproved. And practically, can we actually be this selective anyway? Like I could say, well, IgM is the most important, but you're not going to have an eligible donor at a week post-infection. One encouraging piece is that if you look at one of those studies from China, almost they screened 40 donors, and the overwhelming majority, almost 98%, were had titers, neutralizing antibody titers exceeding 160. So what do the antibody results mean? So the ELISAs in use target antibodies against the receptor binding domain or the full-length spike protein. There seems to be good correlation between the ELISAs targeting spike protein and microneutralization. That's what's shown in those images from one of the cited papers at the bottom. And that there seems to be low cross-reactivity from human coronaviruses. Actually, that suggests that further supports this being an entirely novel agent, the fact that there is such low cross-reactivity. So let's transition a little bit to the research and the clinical trials. So remember the three access pathways. We've got emergency IND, we've got the expanded access program, and now you have this traditional IND mechanism. So there's a whole series, there's a very limited snapshot of all the trials and studies out there. But these are the ones which I'm most familiar with. So the first, which is probably going to get into the field next week, it has IND clearance, it has IRB approval, is a post-exposure prophylaxis trial targeting those who've had a high-risk exposure to healthcare workers and or individuals who have a high-risk exposure and are at high risk of severe disease by virtue of immunocompromise or underlying illness. And so that is really about to enter the field. And then 75 subjects in the treatment arm, 75 subjects in the control arm. The next is early onset of symptoms, also probably within a week or two of entering the field, also has negotiated all the regulatory and administrative hurdles. This is a much larger study, over 1,300 subjects. It will be sites will be all over the country, and this is really patients who have just been diagnosed as outpatients, seeing whether administration of convalescent plasma can stave off progression. There's trials looking at moderate disease, so there's patients who have been hospitalized but not sick enough to warrant ICU admission. You have the Hail Mary, or kind of unfortunate name, rescue intervention for severe COVID-19. So that's really your ICU population. And then you have pediatric protocols looking at safety, post-exposure prophylaxis, and early treatment. So these are all almost ready to go. And at just various levels of development, not development, but just really approval and logistical undertaking. But there's trials, all over internationally as well as in the US. Outside of what's on this is by no means a comprehensive portrayal of what's going on. So other research under the EIND mechanism, there's an opportunity to mine data, the compassionate use data. Under the government-led master protocol, the expanded access program, the sites are reporting data which are being mined as well. There's been over, I believe, several thousands transfusions already under that expanded access program, and can be used to learn something. In terms of the clinical trials, the outcome measures are fairly predictable, and depending on what target population is the focus of that trial. So, for example, post-exposure prophylaxis is really incidence of infection. Early onset of symptoms is hospitalization, and then it goes for hypoxia, intubation, ventilation, and death, depending on where one stands. So most of what we're doing is not really high-end cutting science. It's more managing logistics. So Arturo Casadeville is really the leader of this initiative. He always states logistics. So some of the things that we've been dealing with, regulatory and IRB hurdles, the operational implementation, which is probably 90% of the day, and that spans everything from developing an epic order set. How do we randomize and blind? Blind the study? How do we park the bus to do the collection drive to characterize the units of plasma? On the prophylaxis trial, just some examples of how challenging this is, where we're enrolling subjects who are kind of the purgatory of infection, in that, yes, they're PCR negative, but we don't know yet whether they're actually developing infection because they're so early on. So it introduces challenges surrounding PPE, how to administer transfusion in a community site. For the early treatment trial, where do we treat these patients? How do we conduct community follow-up of known infectious subjects? How do you negotiate a multi-center study, spanning the entire geography of the US? Maintaining an inventory of ABO representative units for each of those participating sites. So these are, enormously complex problems. Also have developed a minimum risk protocol. So what happens is that this is separate from the clinical trials, but it's really to feed the pipeline of convalescent plasma. So what happens is, because at least for Hopkins, we've got a small team headed by someone who was a grant specialist and is now being deployed to kind of participate in this team. 2 med students. And what they're doing is they're doing telephonic screening. They then, if someone is deemed to be eligible, they then schedule a pre-donation specimen collection and testing at 2 of the Hopkins sites. There's actually probably scope for expansion to other sites. The specimen collection, so we're collecting blood and saliva, and then repository samples on top of that. So the samples go for antibody testing, and then there's a series of studies looking at correlation between antibodies and the different specimen types, looking at assay developments, understanding the kinetics of the immune response. And then beyond that, if the donors qualify, so for the clinical trials, we have a fairly stringent antibody titer, which is a little bit different from the expanded access and the EIND mechanism, which don't require as high a titer for vetting of those products. So we schedule collections of either at New York Blood Center or their satellite blood bank of Delmarva or Anne Arundel Medical Center. So this was 1 week. I could update this. We've got many more subjects now, but this was just in 1 week, just looking at the first 18 subjects. What we see is that about almost 80% were IgG positive at this high titer, which is at least 320, which is positive. So all our donors are at least 28 days following symptom resolution. I should have made the point that although the FDA allows for donation between 14 to 28 days, those less than 28 days need a repeat negative swab, which becomes difficult. The other challenge is that a high proportion of those between 14 and 28 days still have positive NP swabs, and it's very difficult to interpret those data. What to do? There's wide ramifications to telling a donor, oh, you're actually, or potential donor, yes, you're still potentially infectious. So I think different groups are looking at what is the interpretation of that finding. But for logistical ease, we and many other blood centers have resorted to just targeting those who are at least 28 days following symptom resolution. What we also notice is that about 80% are IgA negative. But there's cautious interpretation. There's uncertainty as, again, what this means. We don't know what the presence of antibodies, whether that confers protection from reinfection. We don't know how long those antibodies will last. And these are all important problems for vaccine development. So how hospitals can contribute. So firstly, identification of suitable donors. There's local initiatives underway nationally. It's kind of a counterpoint. But there's also plans to geolocate collection sites with ABBs, formerly the American Association of Blood Banks, and ways to streamline pre-donation screening. Hospitals can participate in the different pathways, and most are already, I don't know if most, but many already are. Maintaining awareness of a changing landscape, because every day it is changing, and investigating the different obstacles to workflow. So if at your hospital you're unable to do antibody testing, considering validating one of the tests. Donor recruitment. We've been fortunate that everyone is aware of the pandemic and is affected directly by the pandemic. So there's been self-identification of convalescent donors. There's word of mouth. There's advertising to the public. The blood bank and the hospital websites have been an invaluable resource. The news and social media platforms have been advertising broadly. And then there's also direct referrals from healthcare providers. As well as other proposals include mining of electronic medical records at referring institutions, but that involves some level of HIPAA waivers and other considerations. So a very busy slide. Just the point behind this slide, to go through the detail, is firstly that because hospitals, at least for the EIND mechanism, which is what started, we're identifying, recruiting donors, and then doing the pre-donation testing. They would then send those donors to the blood center, and then you had this directed donor model, which is kind of interesting, where donors would be sent back not for a directed patient, which is the traditional model of directed donation, but sent back to a hospital. There are some, as I mentioned before, some issues of equity on that front. In the bottom left-hand corner, just to mention the collection process. So most of the plasma, at least in the US, is being undertaken through plasmapheresis. It's very efficient. So a single donor can contribute upwards of 600 moles of plasma. So one donor essentially is the equivalent of 2 to 3 plasma products. The plasma is it's frozen within 24 hours of collection, and then it is quarantined. So probably the most important point about this is that all donors, in addition to that, the COVID-related eligibility criteria, need to meet all criteria for community blood donation. So those units still undergo the full battery of infectious disease tests, and in the case of females who have previously been pregnant, there's also HLA antibody testing. So some operational considerations, just a brief mention that the blood bank and transfusion services have been, I don't know if it's an indirect effect, but it's actually a direct effect, that there's pressure on transfusion inventories already. So in terms of inventory management, there's requests for EIND and expanded access plasma, and there's allocation of scarce resources. So there's been a number of questions about dosing and administration. So the dose of convalescent plasma has been highly variable. So historically, some of that variability may be ascribed to differences by indication, as in, was it used for prevention or was it for treatment of a given disease? So lower doses for prevention. The proposed doses for COVID-19 are based on the studies from well, experience in SARS-1, where I think 5 moles per kilogram of plasma at a titer of at least 160 was utilized. Some pharmacologists as calculated what we need, and it comes to conveniently about 200 to 250 mils of plasma, so imparting logistical ease to this whole problem. So for the planned clinical trials, we're proposing 1 unit for post-exposure prophylaxis, 1 to 2 units for treatment. And in the rescue intervention trial, I think they allow up to six doses, but obviously not consecutively, but in the course of treatment, which may be over several days. With pediatric transfusions, there's a need to aliquot and dose by body weight. The administration is thought to be safe, and that's based on data from China, Italy, and now over probably several thousand units of have been transfused in the US. The duration of efficacy is largely unknown. Extrapolating based on the kinetics of IVIG, probably likely a few weeks to several months. So for me, dosing simplified, I look at this as 1 dose of 200 to 250 mils of plasma. And that's your pharmacologist in the top left. It's a Monty Python reference. That's your patient number 1. Those are patient number 2. And so even after accounting for differences in volume of distribution, there's variability in the titers between the products, and you have incomplete characterization of the antibodies. So take it all with a pinch of salt. A unit of plasma is convenient, but it's not necessarily the ideal. So what are the risks? So general risk, I would say that a convalescent plasma probably approximates risk of standard plasma. Donors, again, must satisfy all criteria for community blood donation. Infectious risks, at least in the US and other high-income countries, is extraordinarily low. If you look at HIV, HCV, those are largely modeled risks, approximating, lightning strike or airplane fatality or shark attack. But, of course, if one gets struck by lightning, then, it's not ideal. So these things do happen, but I would characterize that as low risk. In terms of non-infectious risks, there is theoretically there's a high risk of transfusion-related acute lung injury, TRALI, as well as TACO, given the populations that are being treated. So in the case of TRALI, there is theoretical priming of the pulmonary endothelium, but we have standard TRALI mitigation strategies in place, such as screening of Paris female donors. In the case of TACO, remember that these are high-risk patients in terms of cardiorespiratory disease, advanced age, and just to be cautious about administration, although 200 mils is generally well tolerated. Specific risks, in the context of treatment, this shouldn't be an issue, but there's theoretical risk of transfusion-transmitted SARS-CoV-2. Of course, there's no reports to date of transfusion transmission of respiratory viruses. So we don't routinely screen for parainfluenza, other coronaviruses, RSV, things like that. And then also SARS-CoV-2 RNA is rare in blood, particularly of, you can imagine, if in asymptomatic patients. So some of these requirements for being at least to have repeat negative testing between day 14 and day 28 is less of a concern of transfusion transmission. It's more about protecting collection staff from potentially infectious individuals. Antibody dependence enhancements is sometimes raised as a theoretical possibility. This is a phenomenon where antibodies from prior infection exacerbate clinical severity in a subsequent infection. But this typically happens, the classic case where this happens is dengue, where one's infected with one serotype, one develops antibodies against that serotype, and then in a different season, one's exposed to a new serotype. and those antibodies potentiate or exacerbate infection on that second exposure. So, dengue patients do much worse when re-exposed to that new agent. Importantly, there's been no antibody-dependent enhancements observed, reported with use of convalescent plasma for SARS, MERS, or recently with COVID-19. Another something which was raised was the blunting the development of a natural immune response. Included that for completeness because a reviewer pointed that out. I'm not sure if that is a thing. So this was a nice little risk benefits analysis developed by a very smart person at the School of Public Health. So on the x-axis, you've got averted deaths from treatment per 1,000 population. On the y-axis, you have different reproductive numbers, so low to higher. And then let me go through this a little bit. This kind of black bar on the left of each panel is the risk of death from plasma. This is really a doomsday estimate, so that assumes that all fatalities that are reported to the FDA are all ascribed to plasma, which is not the truth. So, most are to other products such as platelets and red cells. But for ease of doing this quantification, we've just assumed that it's all from plasma. And then in the middle, you have the different age groups of this was actually specifically developed for healthcare workers, so ages 20 to 74. And what we see, and there's a range of efficacy. So let me show you that. So on the left, you have relatively ineffective convalescent plasma to 75% efficacy on the right-hand panel. What we notice is that there's actually overwhelming benefits from prophylaxis or treatment with convalescent plasma with respect to averted deaths from administration. So what about the ethics is kind of interesting is if you look at blood utilization in a crisis in general, we're having to allocate blood products in times of shortage. There's been canceled blood drives, there's a contracted donor pool, large part due to restricted travel. Examples of mitigation, sometimes we just we can cap transfusion. So for example, if you have a massive transfusion event, that one simply says, well, beyond 50 units, the survival has been shown to be so low that we're going to stop. There's obviously enormous gray areas, and I can't imagine anyone's actually going to be prescriptive about what to do and what not to do. At least for Hopkins, we have a tiered approach where we're adapting to changes in the inventory, and have managed to contend with this relatively effectively. The ethics specifically to convalescent plasma. So we have, despite people are eager to use this, it is still a product of uncertain efficacy. So there's this general awareness of benefits. There's observational data, but there's potential for confounding. In the context of compassionate use, we're triaging in the absence of robust data of who would benefit most. I would say my personal view is that earlier seems to be better, and that the benefits are probably diminished later on. So, for example, treatments of cytokine storm. But the data are needed to really inform that statement correctly. In terms of the clinical trials, so we're enrolling into treatment trial protocols, but there's also these other alternate access pathways. There's also alternative trial interventions. So, for example, direct acting antivirals and things like that. So, how do we prioritize each of these trial interventions? So, and then of course there may not be enough inventory to support each of the trials. So in terms of the proposed solutions, and that's misspelled, first is prevention. So we're working aggressively to scale up inventory to ensure sufficient supply, so we don't have to triage products by trial. But that raises the question: what is the minimum inventory that would be acceptable if there potentially isn't enough plasma for these alternate access pathways? I'll give you my personal feelings on that in the next slide. The blood center imposes limits to the number of products per patient. So in the expanded access program, one's only allowed 1 to 2 products. Clinical guidelines, which are difficult to develop at the moment, there are insufficient data. There's scarce resource committees, which are ideally separate from the transfusion service and the prescribing providers, so that they can manage the requests for plasma. I've seen proposed lottery systems, so where you have weighting of requests to ensure equitable access to convalescent plasma. You can even have scoring systems, such as which have been used for cancer therapy and organ transplantation. My personal bias is that proposed systems make sense for therapies of established efficacy, but assume and also so I think the trials where we're optimally positioned to actually learn something and really guide practice. I'm obviously very biased because I'm enmeshed in this whole trial apparatus, but I would favor the trials. And importantly, to get this question: is my plasma, where's it going? Is it going to the general population? So it's a little bit of a flawed thinking where we think that the research clinical trial plasma is going to be used for shampoo or something else, where it's actually going to serve the same population that people want it to serve. So, and that covers the full spectrum of disease. So some other questions: how do I participate in clinical trials? In the coming days to weeks, institutions are going to be actively engaged. How do you assist the blood centers? There's some resources and that I'm going to outline. But there's one can perform pre-donation screening, development of a pipeline of convalescent donors, and routing donors to the correct place. And then these are the resources. So at least for us, we've got this email address where it goes straight to our recruitment team, and they follow up immediately. But there's these other websites. So in conclusion, I think convalescent plasma is the only intervention that's readily available for COVID-19. It offers a temporizing strategy pending availability of hyperimmune globulin and vaccines. There are major logistical challenges which have contributed to unmet need. There is scale up underway. There's a rapidly changing landscape of activities, mostly for the positive. There are ethical and clinical considerations about use. I can't emphasize enough the need for rigorous research. Preliminary data suggests that it's safe and offers benefits. There's enormous opportunity for ancillary studies. And then my one sentence pitch is that all the attention is really on high income countries, but this is convalescent plasma, if shown to be effective, could be scaled up in low middle income countries which have a transfusion infrastructure. And then this is probably the most difficult slide to actually generate, because there are so many people. Like, this is totally incomplete. But just some of the highlights, Erin Tobin, in my division, I speak to many times a day. Shmuel Shoham in infectious diseases. Arturo Casadoval, who's led this initiative. We have partners at Mayo Clinic and WashU and elsewhere. The medical centers, Anne Arundel and New York Blood Center, and then just it's easy to forget just the mechanics of each of the steps. We have people in the labs who are staying late into the night to process samples, to qualify donors, and you have these the pre-donation centers who are collecting the samples and have just been instrumental to getting this off the ground. And then, of course, funding, the Bloomberg Foundation in the state of Maryland, without which this would just be imaginary. So thank you. That's where I am mentally right now. That's in Indonesia. But I'm happy to take any questions as they come along.
Thank you, Dr. Bloch, for your excellent overview. I have a few questions that I got from our viewers online. So one question is how far ABO compatibility is considered while giving plasma transfusion?
It's a really excellent question. Comes up a lot. So from my understanding, in the emergency IND and the expanded access program, they don't actually specify. And there is some variability by institutions. So some institutions are giving, say, low titer products, or so they are titering the products, or they are, or they're not. They're just ignoring it. As long as it's below a certain threshold, like below 600 moles of outer group. Per the clinical trials, we have specified ABO compatible, and so one has to adhere to whatever is in one's IND approval. So for us, we're transfusing ABO compatible plasma.
There is another question. Is there any preliminary data on treatment with plasma-derived COV2 hyperimmune globulin?
I think preliminary data, I don't know as yet. So the only preliminary data I can say, which is published, are those studies which are outlined. I don't know if there's been anything brand new, but there is, I can't say anecdotally, but it has. Yeah, it really is anecdotally, because in conversations with those leading the expanded access program, there's been a very high number of transfusions. It seems to be safe. I think that's the only thing we can say at this point. But to answer the question, I don't think we have those data yet.
Thank you. Another question is, has there been any epitope mapping of these neutralizing antibodies?
That's really a superb question. That's something I'm very interested in. I don't believe so yet, but that's critically important to a whole range of problems.
So the next question is, since there is a limiting factor with respect to the amount of plasma you can obtain, has anyone ever produced recombinant human antibodies with the same epitope and used that to treat viral disease?
So at the beginning I said, this is kind of convalescent plasma. People don't like me to say it, but it's kind of the quick and dirty intervention or solution to the problem. Downstream, what is happening in parallel is development of hyperimmune globulin or monoclonal antibodies, which is, I think that's part of that question. The catch is that those pipelines, they go through it's almost like a pharmaceutical manufacturing pipeline. Although it's a derivative of plasma, of sourced plasma, but it's a very different manufacturing process, where the timeline was, when this started, I'd heard, the fall as being optimistic. So those products are not available yet, but I think that's again another critical intervention.
Right. There is another question. Are there any labs in US where neutralization assays are being done currently? How are antibody titers being performed in the clinical trials in the absence of general availability? I think there are two questions.
So there's a huge amount of variability. This is a major issue. So yes, formal neutralization is being done in some labs, but again, that's really a research setting. These are BSL-3 labs. So it's not something which you can just adapt to a clinical setting. There are also pseudo-reporter, pseudo-virus kind of reporter assays which can be performed in a BSL-2 environment. In terms of what's been done for the different studies, there's a whole variety of approaches. So there's ELISA with correlation with, one can do some sort of validation where one correlates one's ELISA output with a neutralization, and then do that. There's reporting of ELISA results, which in turn can be, that's typically reported as an optical density, but that can, there's ways of performing titers in that way as well. So the short answer is that there's everything that you would imagine is actually out there, and it's kind of, in some ways, it's a necessary evil at the moment, because things have happened so fast that we've had to adapt. But I think as we kind of move into the next weeks to months, there'll be a lot more standardization of assays, and there's also their commercial assays, which are now more amenable to high throughput, which can, so part of that testing workflow might be integrated into routine donor screening at the blood center, rather than have to go through some of the problems that hospitals are contending with.
Another question that I found is that is there any benefit of trying plasma in patients with mild disease?
Definitely. Sorry, I probably didn't make that clear enough. So our first trials, so the trials that we're launching first, the first one is post-exposure prophylaxis, as in they've just been exposed, but they don't, they're PCR negative. And then the next one is treatment of early disease. So outpatients with who've just been diagnosed, they are symptomatic, but they don't warrant going into into the hospital. So the ideal would be to stave off progression, and then bypass the need for hospitals. So my feeling is that there probably is benefit, but there's no evidence as yet. So that's why we're doing the trials.
One last question. It seems in the presence of compassionate use of CCP, how do you justify denying some patients in one of the arms of a randomized control trial? Do you think this could be a potential challenge in treating patients?
Yeah, it's a brilliant question. I totally agree with that's that's a major challenge. So I can tell you how. So at least one institution that I've heard about how they're contending with that is that they will. Well, firstly, I should make this clear that this is unproven efficacy. So there is equipoise, which allows for us to do clinical trials. We don't know if it's effective. So if you don't know it's effective, then there's risk benefit. The risk is comparable to kind of waffling. So because there's equipoise, it justifies doing the trial, because we don't know if it's effective. Now, what one institution is doing is that they're communicating to providers, so that if a subject does participate in the trial and there is deterioration, that they are prioritized in terms of getting, I believe, compassionate use plasma. So it's almost like it's kind of a hybrid model, where they start off with with a 50% chance of getting the convalescent plasma, but if they deteriorate, there's still this compassionate use, this opportunity for compassionate use. But it is, I totally agree. I think it is a challenge.
One more question. Can previously pregnant women donate as convalescent plasma donor, or will it cause TRALI?
Oh, sorry. I thought you said actively pregnant. So no, so there's standard screening underway. So as in, if someone has been pregnant previously, they will be screened. So I think part of the donor history questionnaire is, have you previously been pregnant? And it's yes, no. If yes, how many times? And those individuals are then undergo HLA antibody screening, and that's routine for any if this were platelets as well. So the short answer is yes, they can donate, but they'll be screened for HLA antibodies.
I think that's all the questions that we have online for today.
Brilliant.
And thank you, Dr. Bloch, for this very elaborate and informative presentation on convalescent plasma. And you'd be very happy to know that we had over 1,000 viewers from over 20 countries from all over the world. Apart from US, we had viewers from Canada, India, Italy, Vietnam, Bogota, Taiwan, to name a few. So thank you all our viewers for joining us today. And if you like our lectures, please follow our Facebook page, that is Patcast, and also subscribe to our YouTube channel by the same name. And you would remain updated with the upcoming lectures. And tomorrow, actually, we have another Patcast coming up that's on bone-forming tumors, and it will be presented by Dr. Roberto Garcia from New York. And the time is 11 a.m. Eastern time in US. And once again, thank you, Dr. Bloch, for your time and effort. Thank you.
Thank you.